Okay.
Yes, we are good.
Okay. Let's, do you mind advancing for me? Or maybe I can, sorry. Try. Okay. Thank you for the introduction. I appreciate it. And yes, I am a urologist with Advanced Urology Institute here in Clearwater, Florida. And today we're going to talk about men's health and testosterone in general. Just a little bit of a hot topic still, has been over the past couple of years, but a little bit of a hot topic overall. So I know we're going to have lots of questions. So here we go. Go ahead. Thank you. Please advance. Okay, so talking about testosterone, you probably have heard the term anabolic steroid or steroids or injectables or anything like that. So yeah, testosterone is considered one of the quote unquote anabolic steroids. So the compound itself obviously is an organic compound for all of you chemistry lovers. And it's really a lipid based molecule. So there's some differences in the way that testosterone is handled in the body because it is a lipid-based molecule, and we're going to kind of go through that as the presentation goes on. So we can go. All right, so pretty important. This is kind of a big slide. I know there's a lot going on, but this is sort of how testosterone is produced in both the male and the female body. So we're talking about up here is the brain, our hypothalamus. We have a certain pre-hormone called GnRH, which stimulates this little pituitary gland, which is very, very tiny, but very, very important. And that releases the pre-hormones that then stimulate the other organs to make things like testosterone in men. So we're really only talking about men today, so we're going to focus on that. But these pre-hormones are very important because they influence the making of both testosterone as well as sperm or spermatogenesis in men. So in the testicles, not only are we making sperm, but they are largely making the bulk of the testosterone in men. Now, it is important to note, and I'll show you in a couple more slides, that we have these things called adrenal glands, which I'll point out, which sit, two of them right above our kidneys. They look like little triangles. And they also participate in steroid making and building in our bodies, and they're also producing testosterone. And then, like I said, this slide is a little bit busy, so I'm going to kind of go as I'm going to talk a little bit more about these different hormones and pre-hormones as we go on. So next slide, thank you. Okay, so the important thing for us to remember, like I said from the beginning of the presentation, is that a steroid is a lipid-based molecule. So that means it's a fat-based molecule. So that means if you were to drop a bunch of testosterone in water, it would kind of bubble up and float and look like a soap bubble because it's a fat and it's not soluble in water. So our bodies are mostly made of water. So when we talk about testosterone in the body, we can't really use it just sort of floating around the way it is. It's not going to be balanced, it's not going to be usable, and it's not going to be stable. So when you go to the doctor and they draw your blood and they take a blood sample from you and they measure the amount of testosterone in your body, that is largely testosterone that is bound up to other molecules. And the reason for that is because, like we talked about, it's not very stable on its own because it is a fat. So the way that we look at testosterone in general when we draw it is we draw a total testosterone. That takes into account all of the testosterone in the body. So whether it's being made, it's in the bloodstream, it's still in the testicles, it's floating near the adrenal glands, wherever it is, that's all the testosterone in the body. And for the most part, that's bound to a protein because the protein has to carry it. Because again, otherwise, it's just going to sit as a little fat molecule in water and it's not going to work. So for the most part, when we measure that, when we go to the doctor and we measure total testosterone, that is bound up testosterone, which means that at that moment in time, your body's not actually using it. It's just sitting there. So we're going to talk about how to calculate free testosterone from total testosterone, because that's a little bit more of an important factor when we look at testosterone in the body. Obviously, we care about how much is in the body, but what we really care about is how much of this is actually working for us. how much of this is serving as a workhorse and driving a lot of these processes that we need help with from this hormone. So if we look at total testosterone here, that's the tiny little bit of it that's free at any given time. Tiny little bit of it is bound to what's called albumin, very similar to egg white, which is a protein. And then a large amount of it is going to be bound to another protein called a globulin protein, which we can also measure on its own. So the way that we end up figuring out what free testosterone is in the lab, we'll measure total testosterone and we'll measure this globulin. So if we have this number and this number, we can figure out what this number is. And if we look at a normal total testosterone in most men, there's a big, big range, not only in the lab values, as different labs recognize different lows and different highs, but also in men in general. And the reason that this is such a large range is because we're looking at this as normal testosterone over every age group. So a lot of the normal low is considered 250 and a lot of the normal high is considered 1,000 or even up to 1,100. So just kind of important to remember. And I'm going to answer that question. SHBG stands for sex hormone binding globulin, which makes sense because this is a sex hormone based on your gender sex. Let's put it that way. Okay, keep going. Thank you. All right, so I know I said earlier I was going to mention that we have a couple structures that produce testosterone. So in males, the big thing here is the testicles, obviously, that are making up the bulk of the testosterone production. But the important thing to note, too, is that adrenal glands are in men and women. So the testicles, obviously male-only structure. Adrenal glands are found in both men and women. So in both men and women, the adrenal glands make a very small amount of testosterone overall, which accounts for the differences in testosterone levels in men and women. Because like I said, this makes up the bulk of it. So women obviously do not have testicles. They're not making as much. We can go ahead. Thank you. Okay, so important thing to note about testosterone. If you are a chemistry geek and you look at steroid pathways and the pre-hormones and the post-hormones and what they become, a lot of our different hormonal substances can become other substances. So we have something called, and I don't have it on this slide, but DHEA, which you'll see is a big time supplement in a lot of our different nutrition stores. And if you look at vitamins and things like that, DHEA is a pre-hormone that can turn into testosterone and estrogen. And so another important point here is that testosterone can actually turn into estrogen. And the way that happens is with this nice little hormone molecule called aromatase. And this exists in the body and it exists largely in fat cells. So that's going to lead a little bit of a basis for me to discuss why people who have more lipids, more fat cells in their body tend to have less testosterone and more estrogen overall, whether they be men or women. Next slide, thank you. Okay. So this is sort of the ideal situation of what people think of when they think of testosterone and maleness. And that is, you know, we have really good muscle mass. We can work out without any issues and not get tired. We're strong, we're healthy, we have lots of energy, we sleep well, we wake up well. We're sharp, we can answer questions easily, we've got good memory, we have good mood. This is what people think of when they think of testosterone. And there's a very delicate balance between having good qualities associated with testosterone and this going to be too much or out of whack or too little. So there is no optimal testosterone level for every man. And I'm going to say that a few times during this presentation because I think that's very important. Because as physicians, I get the question often, well, what should my testosterone be? And the answer is, well, I don't have an exact number for you. It's not an exact science. So there's a range, and we'd love it if you were somewhere in that range, but we also have to take it into account, how do you feel on an everyday basis? What's your sleep-wake cycle? How does it, how well do you respond to changes in stress? How is your energy? How sharp is your mind? How good is your memory? How easy or hard or difficult is it for you to work out on a regular basis? And so it's not just looking at the numbers, it's looking at the whole person when we talk about testosterone. And then this is sort of where we look at low testosterone. We think that, these people tend to have, they tend to be more tired. They tend to be depressed. They don't really want to do anything. They don't want to get up off the couch. They don't really have any drive, whether it be drive to, get through their day, or drive to, have good libido and have good sexual activity. And so this is sort of the ideal situation that we think of when we look at both. But like I said, there's no exact number that's going to lead to either of these situations. Go ahead, please. Thank you. Okay, another important thing to know is that testosterone as a hormone has a normal daily rhythm in everyone. And so when we wake up in the morning, first thing is when our testosterone should be highest. So as physicians, when we tell you to go and have your testosterone levels drawn at the lab, we're going to ask you to do that first thing in the morning. That's when your testosterone is going to be more accurate, when it's going to be high. If we ask you to get it about 11 a.m., it's probably going to be on the downward slope. Now, if you're lucky, you'll have a little bit of a boost in your testosterone in the early afternoon as well, after lunchtime. Not everyone is like that, but some people are, which is good. But for the most part, it tapers off somewhere around bedtime is when it's going to be your lowest. Go ahead, next slide. Then we also have to talk about your age. Now, testosterone is always touted as the fountain of youth in, men and women. That's not necessarily the case, but I do really want to acknowledge here that there is going to be a decline in everyone in their hormones, in their testosterone as we age. Just like we talk about menopause in women, genitourinary syndrome of menopause, we talk about a decrease in the hormones or a drop off of our hormones at some point in our lifetime, and a lot of people refer to that as menopause. In male patients, there's not such a distinct exact act where the testosterone drops off. It's going to be more of a gradual decline as time goes by. So some people won't feel any issues from lack of testosterone until they're in their 50s. Some people won't feel it until they're in their 80s, and some people may never actually feel it at all. So it's not an exact science with testosterone as it is in menopause with women necessarily, which is yet another reason why every patient has to be looked at as an individual. Thank you. Okay, so what we know testosterone does is it helps with your libido. It helps with increasing red blood cells in the bone marrow. It helps stimulate the sex organs. It helps stimulate hair growth. It really helps with muscle growth, and it really helps keep your bones strong and healthy. We're going to go through these individually. You can go ahead. So in the brain, in infants, it's going to masculinize the infant brain. It's going to help with desire. It's going to improve memory, and it's going to make you feel overall good. Keep going. In the muscle, skin, and bone, in these connective tissues, it's going to work to increase the hair growth, increase muscle growth, the fiber activity of the muscles, and it's going to help them work better. And it's also going to help support the bone mass and density, meaning it's going to build stronger bones. Go ahead. In the sex organs, in the fetus and in infants, it's going to help masculinize the sex organs overall. And we talked about this earlier. It's going to induce sperm production, and it's going to support erectile capacity and activity. Okay, that's important. We'll keep going. In the kidneys, it's going to produce something called erythropoietin. That's a hormone that increases your red blood cell production. These red blood cells are important because that's how we get oxygen to and from the tissues. Too many red blood cells can lead to blood that's too thick and sludgy, and we're going to kind of go over that in the future as well. Go ahead. In the heart and vascular system, we don't know exact science as to how these things happen, but we do know that people have lower testosterone have an increased risk of coronary artery disease, which is disease of vessels of the heart. They have an increase in hardening of the arteries. They have an increase in the cells themselves that are lining the vessels and the arteries. And they also have an increase in what we refer to as cardiovascular events, which is heart attack and stroke. So there then brings this question. Is the increased risk of cardiovascular disease and events in hypogonadal patients due to low testosterone? And that hypogonadal refers to patients that have low testosterone, that we've measured their levels and it's low. Or are these patients that have cardiovascular disease, are they just overall more likely to be in poor health with increased fat tissue, which leads to decreased testosterone because of more estrogen, diabetes, which causes also a lot of hardening of the arteries, and metabolic syndrome, which again is that central fat that takes testosterone and moves it to estrogen. And herein lies the controversy. Thank you for going ahead. So herein lies the controversy. So there was, I think about 5, 6, 7, maybe even 8 years ago, all these studies that were kind of coming out saying, oh, yes, 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 we need to give our older gentlemen testosterone. It's really good. It helps support all these things. Why are we not treating men with testosterone? And then we stepped back and took a look at it and said, well, hold on. We're giving a lot of older men testosterone, and it's actually causing them to have heart attacks, strokes, and other issues, blood clots being another one. And so we kind of backed off of that and said, well, wait a minute, is testosterone causing this? And I think the answer to that question really lies in picking apart these studies, which I'm not going to go into a full discussion here. But what we really need to ask ourselves is, are we treating men at the right time? Because most often what we see is men who in their 50s, 60s, 70s, 80s start really feeling those effects of low testosterone. And maybe they don't talk to their doctor about it. Maybe they wait a while. Maybe they have other things going on. Maybe they wait a little longer. Maybe they wait until it's too late. And at that point in time, a lot of these cardiovascular events have already been set in motion because of other reasons. High blood pressure, diabetes, weight gain, obesity, genetics that can contribute to all of this. And so then all of a sudden, later on in life, we say, oh, no, 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 we can cure you with testosterone. And then these cardiovascular events happen. And then we say, okay, well, it's due to the testosterone. When in reality, if we look at it, it's probably more of all these issues happening at once and the testosterone then contributing. It's kind of like putting the icing on top of the cake or making everything topple over at once. So testosterone is probably not the sole cause of what's going on, but if you're adding it to a perfect storm already, it's probably pushing a lot of patients into the bad area, the red zone, the trouble zone, basically. And so I think that's kind of how we have to look at it as physicians, and how we've really broken down these studies and how most doctors, I think at this point in time, would kind of look at it. It's a fine balance. I know I mentioned that so many times before, but it really is. And again, you have to look at every patient as an individual. So I mentioned metabolic syndrome. You hear about it a lot. What this is people who have high blood pressure, high cholesterol, lots of central fat. So visceral obesity is fat that collects around the tummy area, around the belly button, and in that area. And then we end up also with insulin resistance, this pre-diabetic. We look at our sugars, they tend to be too high in the resting time when you're not eating. And that all adds to these metabolic syndrome pathways, which can infer things like heart attack later on, stroke, blood clots. Like I said, it's kind of setting up for a perfect storm. So testosterone can really set a lot of these things in motion too. We can go ahead. So I get this question a lot. What can I do to boost my testosterone naturally? Or, hey, my cardiologist said I can't take testosterone. What can I do to boost my testosterone naturally? And the answer is, well, there's really no good one food or one supplement or anything that you can do to naturally boost your testosterone. To be healthier overall, what you can do is have a good diet, low in fats, exercise very regularly, and keep up with checking with your physician. But a lot of people here suggest that things like different proteins and things like that can really help offset the decrease in testosterone. What I'm suspect on some of these is, are they just providing protection against some cardiovascular risk? Probably that as well. We can go ahead. Okay, so then we get the question of, okay, well, now my doctor said I can replace my testosterone, so now I'm here to see you. What do I do? I mentioned at the beginning of this that testosterone is a fat-based molecule. So it's very difficult to put a fat-based molecule in a pill, swallow it, and have it work, because it's going to be broken down by your digestive enzymes and it's going to go away, and it's not going to get absorbed at all in your body. So when we talk about testosterone replacement, I'm going to go through the different types. So go ahead. Thank you. So a lot of times you'll see these are injections, these are patches, these are creams. This is an intranasal spray. This is actually the first oral formulation that not the first, but the best oral formulation that they now have out on the market. It shows some progress. It's very difficult to get. I'm going to go ahead with the slides. So whatever you choose with your physician, it's important that we talk about the side effects of it. So anytime you're using your own regular testosterone replacement, remember that your body is no longer being forced to make testosterone. And there's a bit of a feedback loop where your body says, hey, I don't need to work on making this anymore, so I'm just going to stop my own testosterone production. And at the same time, because it's the same pathway, the testicles are going to stop working and they're going to stop making as much sperm. So a lot of times you'll have decreased testicular size and weight. You'll have changes in your skin and hair follicles, usually growth. You'll have increase in PSA. PSA stands for prostate specific antigen. That's the blood test that we use as a screening test for prostate cancer. Because testosterone feeds the prostate, it can increase your PSA. PSA measures how much your prostate is working. So this may be a false elevation, in other words. Giving back testosterone can cause you to have mood swings, can change your sleep patterns, can increase your red blood cell counts. We talked about thickening of the blood, polycythemia, and that can be dangerous, especially if we're worried about blood clots. Go ahead. Sorry, on that last slide, I just wanted to comment that I get this question a lot: is prostate cancer caused by testosterone replacement? And the answer is basically no. But if you are a patient who already has prostate cancer, if you are a patient who genetically probably will have prostate cancer in the future, or if you're somebody who has prostate cancer cells that are unknown at that time, testosterone will feed it and make it much worse. So it's not necessarily the sole cause of prostate cancer, but it can feed it and make that grow and worse. We can go ahead. And just the last couple slides here, I get this question so many times as a physician, where people bring in their nice little bottle of this testosterone supplement that they bought at the drugstore or the nutrition store, and they say, hey, I spent $90 on this. Tell me what you think of it. So this was a nice article that broke down 5 of the most common types of testosterone replacement or supplementations. And really the important thing is here that you're going to look at, and what I tell patients is, go ahead and read me the ingredients on the label. And they'll say, okay, and they'll look at it and they'll read me the ingredients and we'll go through it, and they'll be like, a lot of times, hey, I can't really pronounce that word. And they'll say, okay, so we go through it together. And then I say, I don't see testosterone as an ingredient at all in here. And they'll say, you're right, there's no testosterone in here. So what's really important to get out of this essentially is that testosterone is a molecule, is a drug, is a medication that's regulated by physicians and pharmacists. It is not an over-the-counter supplement that can just be picked up from the nutrition store or the pharmacy or the grocery store and taken. So these supplements are not going to have testosterone in them. They are going to have lots of other little things that may help, et cetera, lots of vitamins and things like that, but no actual testosterone is going to be in these supplements. And I'll show you on the next slide. So this was, this was an article that was really nice. They looked at all this literature review on the 10 most common testosterone booster ingredients. And as you can see here, none of these are testosterone. Horny goatweed, see it all the time. It's in everything. Still not really sure what it does, but saw palmetto, this is another one. No increase in testosterone ever that we can see with saw palmetto. Messes with your PSA, but not necessarily your testosterone. This is another real popular one I get a lot. Ashwagandha root extract. Again, don't really know what it does, but I don't see it working like testosterone by any means. So that is our discussion. Thank you. You can, I think the next slide says thank you, and open to questions.
Thank you so much. That was so informative. And I think it's something that people don't always think about. Even for the females in the group, we have husbands and children that we deal with. So it's kind of nice to be able to get that information. I am getting to the chat. For some reason, I'm having trouble getting there. So we will see who is in the chat to see what questions that we have. So actually, we don't have any questions. So we'll give people a moment. If you have any questions, please type them into the chat for us. I think if you're thinking of somebody, we have one. That saw palmetto. If you could talk a little bit more about that, about the prostate.
No problem. So there is a wonderful article in the New England Journal of Medicine that came out about 10 years ago, I think 8 to 10 years ago. And people have been using saw palmetto for years and years and years, and they've been using it to help with a lot of their urinary symptoms secondary to enlarged prostate. And a lot of people take saw palmetto and they say, listen, I get up less to pee at night. I pee less frequently during the day. I have better flow. Saw palmetto works. So it's been touted for a long time to help with prostate health. So actually has nothing to do with testosterone. And we know that patients use it because they think it performs similar to Flomax or tamsulosin or finasteride, or all those things that tend to help the prostate